So I've received your questions about chronic bronchitis. Yes, I see them. Said, yes, thanks for these questions, and I will answer these questions. Take your pens, papers, my beloved students. Actually, it will be helpful not for your final board exams, but as well as for your future medical practice. No, I hope so. So, chronic bronchitis, my beloveds, it's a clinical diagnosis. It's a clinical diagnosis. It's a clinical fact. It's not a radiological one. So chronic bronchitis is defined clinically as a productive cough that lasts for at least 3 months per year for 2 consecutive years. So a chest X-ray may be normal or show only non-specific changes. Is diagnosed by symptoms. Samaj guy? Smoking, next point. Yes, smoking is the prime suspect. But not the only one culprit. Definitely, cigarette smoking is the most common cause. Absolutely, accounting for the vast majority of cases. So no doubt about that. However, long-term exposure to other irritants such as, you name it, air pollution, dust, fumes, and second-hand smoke can also lead to chronic bronchitis, especially in non-smokers, and exacerbate the smoker status. So think of occupational exposure like mining, agriculture, and construction, my beloveds. So it's a major component of chronic obstructive pulmonary disease? Yes. Yes, my son, but not always. While chronic bronchitis is often associated with COPD, the chronic obstructive pulmonary disease, they are not synonymous. Chronic obstructive pulmonary disease, it's a broader term encompassing both chronic bronchitis and emphysema. Of course, emphysema, it's a radiological data. It's imaging data. You can have chronic bronchitis without airflow obstruction, which is the defining feature of chronic obstructive pulmonary disease on spirometry. However, many patients with chronic bronchitis do eventually develop chronic obstructive pulmonary disease. So we can say that chronic obstructive pulmonary disease is the end stage of chronic bronchitis. Why not? Why not, my son? Good question. About pathophysiology, my beloveds, the pathophysiology is more than just mucus. While excessive mucus production is a hallmark of chronic bronchitis, that's why we ask this question about cough and chronic bronchitis in the mornings. The underlying pathophysiology is complex. It involves chronic inflammation of the bronchial airways leading to hypertrophy and hyperplasia of goblet cells, which produce the mucus. Impaired mucociliary clearance, the process that removes mucus, and bronchial wall thickening. This remodeling is a key to disease progression. Then, airway infections are both cause and consequence. Yes, airway infections are both cause and consequence. Frequent respiratory infections, both viral, bacterial, can contribute to development or exacerbation for this chronic bronchitis. Yes, my son, the daughter. The damaged airways are more susceptible to infection, and these infections in turn perpetuate the inflammatory cycle. Vicious cycle. Consider, my beloveds, influenza, Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis are as common culprits. Symptoms extend beyond the cough. Yeah. While a productive cough is the defining symptom, patients with chronic bronchitis often experience other symptoms, including shortness of breath, especially with exertion, wheezing, chest tightness and fatigue, cyanosis, So bluish discoloration of the skin can occur in severe cases, leading to the term so-called blue bloaters. Blue bloaters. About pulmonary hypertension. Pulmonary hypertension and cor pulmonale are serious complications in severe, long-standing chronic bronchitis, chronic hypoxemia, low blood oxygen levels, no in blood of course, low blood oxygen levels, can lead to pulmonary vasoconstriction, increasing pressure in the pulmonary arteries. These can lead to pulmonary hypertension and eventually cor pulmonale. Cor pulmonale means right-sided heart failure. As the right ventricle struggles to pump against the increased pressure. That's why we have this pulmonary hypertension. Spirometry. Spirometry is crucial for diagnosis and management. While chronic bronchitis is diagnosed clinically, of course, spirometry, pulmonary function testing, is essential for assessing the severity of airflow obstruction and differentiating it from other lung diseases, such as asthma, for example. It helps determine if the patient has progressed COPD, chronic obstructive pulmonary disease. Of course, Kim and Wito used to talk about that. Key measurements include FEV1, FEV1, no, it's an acronym, means forced expiratory volume in first second, and FVC. FE1 is a forced expiratory volume in first second, FVC, forced vital capacity. So a reduced ratio FEV1 to FVC ratio is characteristic of chronic obstructive pulmonary disease. Management is multifaceted, not just bronchodilators at all. While bronchodilators, beta agonists, and anticholinergics are often used to relieve symptoms, management of chronic bronchitis requires a comprehensive approach. This includes definitely smoking cessation, pulmonary rehabilitation, exercise training, and blowing balloons, exercise training and education, influenza and pneumococcal vaccinations. Actually, it's a little bit debated, controversial, a lot of controversial. But anyway, you answer on the big exams: influenza, pneumococcal vaccinations, and inhaled corticosteroids, actually often combined with long-acting beta-agonists in COPD. Mucolytics, for example, N-acetylcysteine. Actually, I don't know how to pronounce this. N-acetylcysteine or cysteine. Actually, I don't know. You pronounce as it correct in English. So N-acetylcysteine may be helpful in some patients, but are not universally recommended. Exacerbations. Yes, exacerbations are a major source of morbidity and mortality. Acute exacerbations of chronic bronchitis are characterized by worsening symptoms such as increased cough, sputum production, and shortness of breath. These exacerbations often require, my beloved, treatment with antibiotics or with corticosteroids. Frequent exacerbations lead to more rapid decline in lung function and higher risk of hospitalization and death. Prevention of exacerbation through proactive management is key. Consider prescribing antibiotics for patients to have at home if frequent exacerbations. Consider prescribing antibiotics for patients to have at home if frequent exacerbations. So key point, my beloveds, or key considerations, up to you how to pronounce. So key points for you, my young medical students, no future medical doctors, medical doctors. So early recognition, my beloveds, take a thorough smoking history and ask about environmental occupation exposure. Don't dismiss a chronic cough as just a smoker's cough. Actually, when you ask question, do you smoke or not, if patient keeps smoking, ask this question: why did your kid smoking? Differential diagnosis. Consider other causes of chronic cough such as asthma, postnasal drip, GERD, gastroesophageal reflux disease, and bronchiectasis. Patient education. Emphasize the importance of smoking cessation and adherence to medical regimes and be a good example. Don't smoke. It's savage for a doctor to smoke. Then rehab. Pulmonary rehabilitation refers to patients to pulmonary rehabilitation programs which can significantly improve their quality of life. You know, it's aerobic exercises, walking, blowing, etc., etc. Proactive management. Aggressively treat exacerbations and focus on preventing future episodes. And subscribe my Dr. Y Telegram channel. What is this history? So I created this channel for you, Dr. Y Telegram. So not only Dr. Y YouTube, it's great that you subscribe this channel and follow and subscribe. I see a lot of new subscribers. My beloveds, I created a special private channel for you, my young colleagues. Dr. Y, W-H-Y, the same name like in YouTube, in Telegram. So how to find this channel? Tap in searching mode in Telegram, Dr. Y, like question, W-H-Y. Find this channel, click start and choose your plan. It's not costly at all, very cheapy. And there are a lot of questions like this, questions, answers, MCQ tests, cheat sheets if you want for students, cheat sheets, very interesting medical cases, and so on. What is this? God bless you.